So thank you very much for coming, and I want to thank also Rexon for inviting me and giving me the possibility to share my experience with you with this new innovative, interesting device that I have been using for 7 months. So it is my first cases, but really very promising. So I want to introduce myself. I'm an ophthalmology and I work in Milan. I'm also a surgeon, so I do cataract and refractive surgery, and I'm interested in this field of ophthalmology, I mean dry eye, because you know that there are a lot of patients that are suffering from dry eye disease, and also because there is a strict correlation between dry eye and anterior segment surgery. So anytime you have a new instrument and a new technology that you can use, I think it's very, very important to know why, how, and when we can use this new technology. So, going back a little bit, let me see if I need probably the, doesn't work. Okay. Okay, thank you very much. Going back to the definition of dry eye, you can see that first of all we need to, knowing the definition, that is the last definition that was performed by the DUS2 meeting in 2017. There will be another meeting in 2020. Of course, that there will be some changes probably, but now the definition you can see here is a multifactorial disease, so a complicated disease where you can find ocular surface damage, you can find hyperosmolarity, you can find visual fluctuation. And I think that if you want to make a proper diagnosis in order to decide which is the best therapy for your patient, you must check all this data before deciding what to do, which therapy may be the most effective for our patient. So, we know that it is a common condition. We know that dry eye disease requires specific and appropriate diagnostic tools, and of course requires particular and individualized multifactorial and multidisciplinary treatment. And this is another flow chart done by the DUS2 meeting. I think that is very, very important, because anytime we have to treat a patient, a dry eye patient, first of all we have to screen our patient, asking him for his anamnesis, if there are some risk factor or some other diseases that can cause dry eye, and then we can ask about symptomatology, about his symptoms, and then we move on with the instrumental approach and the instrumental analysis. In order to check and to classify, to place our patient in case of dry eye patient for excessive evaporation, or in the group of patient, dry eye patient with aqueous deficiency. So in this flow chart you can see that the majority of patients is the yellow patient, are patient with excessive evaporation, but still remain a group of patients that have also aqueous deficiency. And so when we have to check our patients, we can find patients that have a mix of both these situations. So, I mean, they have a mix of aqueous deficiency and meibomian gland deficiency. That means these patients suffer from an hyposecretive dry eye, and this is probably the most common condition. It's very difficult to find patients that have only one typical condition, one typical dry eye, like meibomian gland dysfunction or lacrimal gland dysfunction. And so the approach is just to classify our patient, but we know that using this device, we can treat both kind of patient in the left part of the graph and in the right part of the graph. That means with lacrimal gland dysfunction and with meibomian gland dysfunction. And knowing that dry eye disease is now very common, and of course meibomian gland dysfunction is much more common in the group of old patients that are suffering from dry eye. And this is because we know that the role of a lipid layer that is very important to protect the tear film, to protect against the desiccation, and to protect corneal nociceptors. We know that anytime we have a thin lipid layer, so we have a meibomian gland dysfunction, our patient may have a severe dry eye. And so, which are the most important exams that we have to do before using also a new technique, a very important and very interesting technique like this? I usually do all these exams before doing before suggesting my therapy to my patients. And we will see in a while, each one by one, all these exams. First of all, I start evaluating the osmolarity, because osmolarity gives you the possibility to share your patient in dry eye patient and not dry eye patient. I mean, if you do these exams in a proper condition, that means that you do like the first exams and not without air conditioning like in this situation. I think that if you find some data like the ones that you can see, if the patient has a condition that is over 320 millismol per liter, or the two eyes have the difference in between the two that is higher than 80 millismol per liter, that means that the tear film is not stable, and so the patient suffers from dry eye disease. So, osmolarity test gives you information because you can have a patient with high osmolarity values and of course also important symptoms, but you can have also high osmolarity with no symptoms, and in this case you can of course suggest a therapy in order not to prevent symptoms, particular important symptoms to your patient, but you can have also normal values and you can have symptomatic patients. In this case, I think that it's better to check also for other causes of your patient's symptoms. So this is the reason why osmolarity test is important, but it is not enough to classify your dry eye patient. So you have to move forward, and the second exam that I think that is very important is the non-invasive breakup time, because it gives you information about the quality of the tear film. You know that the longer the tear film remains on the corneal surface, the better it is to have a healthy ocular surface. So in the case of very low values, you can have very important symptoms of your patients, but in this case you can have, of course, a dry eye disease, but you don't know which kind of dry eye disease, because these values may be influenced both by aqueous deficiencies and meibomian gland dysfunction. So you have to do another exam that is called interferometry and evaluates the lipid layer thickness. This is strictly correlated, on the other hand, to the MGD, so to meibomian gland dysfunction, because meibomian glands are the ones that are producing the meibum, and so if the meibomian glands are not working properly, you have a very thin lipid layer. Usually it is associated to low Nibud value and often is alterated in case of chronic eyelid disease. This is an example of lipid layer thickness. You can see on the left side a transparent tear film. That means that the lipid layer is very thin. On the right part of the slide, you can see a whitish tear film. That means that the lipid layer is thicker. And after doing that, now we have to check also the state, the functionality of the meibomian glands. And we can do this doing the meibography, because the meibography gives you information about the meibomian gland loss or dysfunction. It is usually correlated in case of dry eye disease. It is correlated to eyelid disease like ectropium, lagophthalmos, or chronic blepharitis or blepharoconjunctivitis. Usually, if you have a patient with a chronic disease like a chronic blepharitis, the HOSD values, the questionnaire values are very high, and also the inflammatory test, that means the MMP9 biomarker, is positive. And this condition requires both instrumental and a pharmacological approach. This is an example of meibography, and you can see how you can see very well all the meibomian glands, and if they are dilated, if they are obstructed, and this gives you important information combined to all the other. And this is another example, another image of meibomian glands. Then another important exam that we have to do in order to classify our dry eye patient is the tear meniscus. I prefer to do the tear meniscus as not the shimmer test, because you know that the shimmer test is much more correlated or maybe alterated by corneal sensitivity. Tear meniscus, no, so it's much better to check in aqueous deficiency. This is correlated to lacrimal gland dysfunction. Usually patient with very, very poor tear meniscus has a systemic immunocorrelated disease. Usually it is also associated to low NIBUT values and hyperosmolarity, and sometimes also the inflammatory test is positive. Of course, it's important to check about the integrity of the ocular surface, and we do this doing the staining test with the Oxford scale, and so we can see if the patient has a situation like you can see on the left part of the slide, where you can see all the damage, the epithelium damage on the corneal surface, and you can imagine how the patient can suffer from this situation in terms of visual acuity and also in terms of discomfort. And this means that the OSD value may be very, very high in this situation. This is the OSD questionnaire, the one that I've been using, and this is from Allergan. This is, for me, it's very easy, but now there are many other questionnaires that are available on the market that you can use just in checking your patient. And this is the inflammatory test that evaluating for the MMP9 biomarker and evaluating for chronic inflammation. It's important also to put all this data together, and I like to show my patients all this data together just to let them know how the situation is and how and why I suggest a specific therapy and not another. And here you can see all the treatment that we can do in case of dry eye. You can of course use lacrimal substitutes, artificial tears, and they can have inside acid hyaluronic acid or lipids. You can use steroids, you can use cyclosporine, you can prescribe also a perfect eyelid hygiene in case of blepharitis, chronic blepharitis. You can also prescribe antibiotics, especially tetracycline, in case of blepharitis. You can also suggest warm compresses, ointments, supplements like omega-3. I use sometimes the plugs just to stop just to maintain for longer time the tear meniscus on the ocular surface, and of course now we have some instrumental therapies. Let's have a look at these new emerging technologies that now are available on the market. LipiFlow is one of them. You know that the LipiFlow is what we call a thermal massage on the eyelid. This is effective in disobstructing the meibomian glands, but probably you know that it's very expensive, and the results are not so, that don't last for so long. And usually you need this approach combined with another if you want to get better results. You can also stimulate your lacrimal gland using the TruTear by Allergan, but I think also in this case you have very short benefits, and I don't think it is very comfortable for your patients. You can use also IPL. You know that I've been using IPL for a long time, and the results are quite good, but only for meibomian gland dysfunction. So it means only for excessive evaporation, that of course it's a common disease, but the most of all your patients have a mix of both aqueous deficiency or excessive evaporation, and excessive evaporation with meibomian gland dysfunction. So I think that sometimes it's not enough. And finally, now we have Rexon-Eye. So Rexon-Eye, with this new technology, new treatment that is called QMR, it is for all types of dry eye. So it is for me, it's very interesting, and it's very promising, because you can treat the symptoms and solve the problem, not only have a patient symptom relief. And this is very important because of its regenerating effect on the tissue and the cells of the glands cells. So why I decided to use QMR? Because I like this technology because it is very innovative, but innovative for ophthalmology, but it is based, as you could see before, because it was used for years in other medical specialties, like the plastic medicine, the aesthetic medicine, and I like its capability to regenerate the cells. And so it was successfully applied in dermatology for wound repair, aesthetic medicine, as I told you, and now it's a very interesting approach also to treat, but also, completely solve dry eye disease. And I think that this is very important, combined to the fact that they don't report any kind of side effects. In all the patients that were treated in their important clinical studies that are now conducted, that were conducted and are conducted nowadays in different parts of the world, in Europe, in Asia, and in Latin America. So I think that the QMR candidates are patients with hyposecretive dry eye. Hyposecretive means, as I told you, lacrimal gland dysfunction, but also with meibomian gland dysfunction. So you can treat both this kind of dry eye disease. So patients with immunological sometimes and endocrinological disease, this patient may have low tear meniscus and or meibomian gland dysfunction, that means a thin lipid layer. These patients are usually patients that keep on using for a long period steroid or cyclosporin, and of course lacrimal substitute. Okay, and this is my short series that, as I told you, I started using this device 7 months ago, and these are my 6 my first 6 patients, now I treated more than 6 patients, of course I treated the double of this number, but the results are almost the same. And as you can see here, these first 6 patients were really difficult cases because all these patients had a very poor lipid layer thickness, they had a very poor tear meniscus, they had a very low NIBUT values, and also the questionnaire was really bad with a lot of complaining, and also the inflammatory in the majority of these patients were positive. That means that they suffer from a chronic inflammation. And as you can see in now I go back to the first slide, to the previous slide, you can see that in the post-operative evaluation, the majority of patients had an improvement in the lipid layer thickness, an improvement in the tear meniscus, an improvement in the NIBUT values, and also the OSD, of course, decreased, and the inflammatory test shifted from positive to negative. So, in conclusion, I can say that of course, a good patient training is necessary for perfect patient compliance. I mean, you must say to your patient that they must come back 4 times in a month, so 1 time per week for 20 minutes, just to remain with the Google on for 30 minutes listening to music. This is not, it's a comfortable situation, of course, but they must know also that the results sometimes are not so immediate. Takes 1 to 2 months to have important benefits, and the improvements are getting better and better within the first 4 or 5 months, and then become stable with time. We have no side effects, and I think that the patient selection is still mandatory, but it's not so important if we compare with to other techniques, like the IPL, LipiFlow, and so on. And I think that, but I think that also in this case, it's very important to combine different approaches just to have better results. I mean, I prefer to treat my patient, of course, with this instrument, but also I prescribe a medical therapy to all my patients during the treatment, and then seeing the results, seeing the benefits, the patient by himself will decide to stop all the other therapy, I mean to use, for instance, the artificial tears. I think that sometimes it can be useful also to use different techniques, I mean just to improve the results and to have better results. And at the moment, I think that probably another thing that we can study and we can check is the possibility to change a little bit the protocol just to make, to have not only better result but faster result. But in conclusion, I can say that I'm happy with this device. I think it is really, maybe it's very interesting because maybe the right instrument to solve and not only to treat the dry eye disease. I thank you very much.